Okay, so we can start the session now. Now there is one question about the sign which is seen when there is arrangement of the femoral vein, great saphenous vein, and the femoral artery. So just because of this arrangement of these structures, the outlook, it looks like a specific sign. So that sign is known as the Mickey Mouse sign. Okay, so that sign is known as the Mickey Mouse sign, and we know that the great saphenous vein drains into the femoral vein, right? So, and the femoral artery is medial to the femoral vein, right? So if we just have a little bit of anatomy of the femoral triangle region, so this is the femoral artery, right? So this is the femoral artery, and then medial to the femoral artery lies the femoral vein, right? So this is the femoral vein, okay? And then the great saphenous vein drains into the, so this is femoral vein, and this is the great saphenous vein, and the great saphenous vein drains into the femoral vein. KK, good morning. Good morning. So this is the arrangement, right, at the in the femoral triangle. So if we write it like this is lateral, okay, and this is the medial. Clear? Now if we take the view somewhat at this level, we will see the arrangement of, yes KK, you are absolutely right, that is Mickey Mouse sign. So the arrangement just looks like the head of Mickey Mouse, right? So if we see it in the ultrasound here, now you can see this is the saphenous vein, right? This is the femoral vein, okay, right? So this is the femoral vein, and this is the femoral artery. Of course, this side is lateral and this side is the medial, okay? So this is looking somewhat like this particular appearance, and therefore it is known as the Mickey Mouse sign, right? So although it's not that important question, but just because it is very peculiar, so I thought of keeping it. So this is Mickey Mouse sign and the typical arrangement of the vessels in the femoral triangle, right? So even if you look in the image, you can see this is the femoral artery, right? So this is the femoral artery, and as in relation to the femoral vein, it is of course lateral. Clear? And then this is the femoral vein here, okay? So this is the femoral vein, right? And we can see this is the great saphenous vein, which is coming and draining into the femoral vein, right? So this particular arrangement creates a Mickey Mouse sign, right? So that is Mickey Mouse sign. Now a very basic question, the radiation dose monitoring in occupational persons, right? The persons who are working in radiology setups, like the technicians and all. So we have to check like what amount of radiation they have been exposed to, right? So that radiation dose monitoring is done by a device. Now what is that device known as? So the monitoring of the radiation exposure of the personals working in the radiology department, and yes, anyone? What is this device known as, which we use to monitor the amount of radiation exposure to the persons working in the radiology setup? And if you see here, this is that device, and this is known as thermoluminescence dosimetry, right? So this is thermoluminescence dosimetry, okay? So thermoluminescence luminescence dosimetry. Clear? And in short, yes, KK, this is TLD. In short, this is known as TLD. So thermoluminescence dosimetry, and the readings has to be read every 3 months, right? So reading has to be read every 3 months. Clear? So this is the TLD badge. Fine? Right. So now a CT scan has been given, right? A CT scan has been given and it is showing some cystic lesions, but more importantly with calcification and in the suprasellar region, right? So now here the classical clue is calcification, and of course the second clue is the site of this lesion. Now can anyone think of the answer? See, in terms of calcification, I would request all of you to remember at least 2 entities, right? So one is neurocysticercosis, right? So I think most of you must be knowing the tinea solium, and the second is the question itself, like, and this is craniopharyngioma. Clear? So as far as the calcification is concerned, please remember these 2. So parenchymal calcification you can say, or brain tissue calcification you can say. So just remember these 2 conditions, neurocysticercosis and craniopharyngioma. So now if you take this word suprasellar, now supra means above, sellar means is actually the dorsum celli, right? So that is one landmark that is known as dorsum celli. Now if we go a little bit into the anatomy of the dorsum celli, so we have to take the sphenoid bone, right? So we have to take the yes, KK, craniopharyngioma, right? So this is the sphenoid bone, right? And we are taking a sagittal section. This is of course the ear sinus. So sphenoid ear sinus, okay, this one, and we know that it opens into the supreme meatus in the lateral wall of nose, okay? So supreme meatus of lateral wall of nose. Fine. Now coming back to the topic as such, now this is the sella turcica. Clear? And I think most of you must be knowing what sella turcica is and why it is so important in our discussions, because it lodges the pituitary gland, right? So it lodges the pituitary gland, right? Now this part is known as the dorsum celli. Okay, so this is the dorsum celli. Clear? So this is, whenever I am saying suprasellar, it means I am talking something in relation to this area, right? So that is what now this is sagittal section, and the CT scan which has been given to us in the question is actually a transverse section. So again you have to you have to capitalize everything in a 3D format in your brain, because sometimes it's just you have to rotate the structures in your brain and then you have to interpret, okay, it will be it will look something like this in sagittal, in transverse it will be like this, in coronal it will be like this. So of course it is slightly difficult from a neurology point of view, because we have to presume the 3D image of that structure, right? Now this is the transverse section, okay, and this area is actually the area of optic chiasma. If you see, this is the area of optic chiasma, and I think most of you must be knowing what optic chiasma is. And from here the optic nerve is coming, and something like this, then the nasal fibers, they will cross over. Okay, so the nasal fibers will cross over and the temporal fibers will continue on the same side. So this area is the optic chiasma, right? And we know that optic chiasma is related to the pituitary gland somewhere above here. So here is the, it is the location of the optic chiasma somewhere here. So this is the optic chiasma. Clear? Anyway, so what I mean to say, that this area is suprasellar region, and because it is related to dorsum celli or sella turcica, right? So this is the suprasellar area, and the moment you have this kind of question, especially related to brain calcification involving the area somewhere around the sella turcica or dorsum celli, think of craniopharyngioma, right? So that's quite obvious. Now this is a coronal section. Okay, I have just taken a pathology image. So this is a coronal section, and here we can see the pathology somewhere above the region of sella turcica, and it can have cystic, but more importantly calcified lesion as well, right? So this is suprasellar region, calcification with some patches of cystic lesions, all goes in favor of craniopharyngioma. Okay, chalo, next move on to next question. And this question is again a very common question which has been repeated many times. Now here some clues are already given to you, and the perfect clue is upper extremity hypertension, and then a chest x-ray has been given. Yes, although in the exam you won't have any markings like this to assist you, but yeah, I have kept a x-ray just to understand the concept, and so that you can apply this knowledge in the exam if there is such a question, right? So the moment you have, wonderful KK, wonderful, the moment you have this term upper extremity hypertension, lower extremity hypotension, clear? This is a classical clinical presentation of coarctation of aorta, right? So this is classical presentation of coarctation of aorta. Now on x-ray you have to look for two things. As in this case you can classically see there is a 3 sign, right? So this is 3 sign, and secondly what you will see, suppose if this is a rib, you will see there is notching of the inferior surfaces of the rib, right? So there is notching of the inferior surfaces of the rib. So inferior rib notching, right? So these are two important x-ray findings which you have to look in the x-ray, which is related to coarctation of aorta. Now before you understand the x-ray changes, you have to understand the pathology a little bit, right? So in coarctation of aorta, what happens, there is narrowing of aorta just distal to origin of left subclavian artery, right? So I think most of you must be knowing this is the actual pathology, right? So there is narrowing of the aorta. Now what happens, because of this narrowing, there is some dilatation of, suppose if you take, like this is left subclavian artery, right? This is left subclavian artery, then this is aorta. You will have some narrowing like this, okay? So this is the coarctation of aorta. Now because of this narrowing, there will be some dilatation above, okay, and there will be some dilatation below. So what happens, this dilatation actually gives you an impression of 3, right? So that is why you find a 3 sign on chest x-ray. So this is the basis of 3 sign, right? So that is explained. Now why do we get this inferior rib notching? What happens, whenever there is coarctation, the collaterals, they open up, right? So collaterals open up, and then when they open up, the location is somewhere in this region, and they will put pressure on the inferior border of the rib. Therefore, you will get inferior rib notching. So again, if I can suppose this is the normal rib, right? So this is, you can say this is a normal rib. This is upper border and this is the lower border. Now what you will see in a case of coarctation of aorta, upper border is perfect, right? But what happens in lower border, you will see slight notching, right? So this is the inferior border rib notching. Okay, so this has to be remembered, and these two signs are quite sufficient, of course assisted with the clinical presentation, and I think there is no point in getting wrong in such MCQ, right? So please remember this much, just two signs, the 3 sign and the inferior rib notching sign, right? Great, let's move forward. So again, you can see a classical 3 sign and the inferior rib notching. Now if you have this kind of x-ray and it doesn't need much of clinical inputs, the moment you see the x-ray, I think most of you can answer this is a classical case of, yes, I am waiting for your answers. This is a classical case. Wonderful KK, wonderful KK. This is a boot-shaped heart, right? This is a boot-shaped heart, and yes, so whenever we say boot-shaped heart, of course we are taking Tetralogy of Fallot, and now in Tetralogy of Fallot you have to, wonderful Ishan, wonderful, you are right. Now you have to get to know the 4 components of Tetralogy of Fallot, because when we say tetralogy is of course 4 component, right? So now the 4 component is, one is VSD, right? Second is right ventricular hypertrophy. Then third component is pulmonary stenosis, and fourth component is overriding of arch of aorta, right? So I think most of you must be knowing. Yes, KK, very good. Right ventricular hypertrophy is one. Yes, this is right ventricular hypertrophy. Then second is the VSD. Third is pulmonary stenosis, and fourth is overriding of the arch of aorta, right? So I think most of you must be knowing these 4 components. Now how these 4 components are creating the impression on x-ray, that you have to understand, and if you get to know the basic concept, I think you will be never wrong in this kind of questions, right? So whenever we are discussing about the boot-shaped heart, one thing is that there is upliftment of the apex, right? So the apex of the heart, which actually is something like this. Okay, so the apex of heart is something like this. Normally it is like this, but here you can see it has gone upward. So there is upliftment of the apex of heart, right? So you can say there is upliftment of the apex of the heart, right? Number 2, there is this boot shape. This is principally because of right ventricular hypertrophy. And why there is right ventricular hypertrophy? Because the blood is going from left ventricle through the VSD to the right ventricle, right? And this is putting a lot of volume of blood into the right ventricle, and the channel of the outflow of the blood from the right ventricle, that is pulmonary valve, it is also stenosed. So there is a lot of work the right ventricle has to do, and therefore it gets hypertrophied, and this manifests as the boot-shaped heart, right? This is one component for this manifestation. Now if you look here, there is a yellow arrow here, right? So if you look here, there is a yellow arrow. Now this is also significant. You can see the concavity here, and this concavity is just because that there is pulmonary stenosis and there is no prominence of the pulmonary trunk, right? Because normally what we see in a normal X-ray, we usually see something like this, right? So if there is aorta which is coming like this, right, then we see the pulmonary trunk something like this. Okay, so there has to be a impression of pulmonary stenosis, pulmonary trunk. But if there is pulmonary stenosis, obviously the blood is not going into the pulmonary trunk, and therefore you can say it is hypoplastic. You can say something like that, and therefore it creates a concavity, right? So there are two reasons for this appearance. One is right ventricular hypertrophy and the second is pulmonary stenosis, right? And therefore you get a typical boot-shaped heart. Okay, so I think now you must have understood the concept. So again, there is lifting of the apex, right ventricular hypertrophy, and pulmonary stenosis. That what gives you a typical boot-shaped heart of Tetralogy of Fallot. So I think now you won't err in this kind of question. Chalo, moving forward. Now this is again a very important concept, and although you can reach up to the answer easily, but I would like to take the concept, and that's why I have kept this question. So here a lady had a sudden onset of headache with neck rigidity, and there is no history of trauma, and then the CT scan has been done. Wonderful, Ishan, wonderful, KK. Yes, all of you can get the right answer. Very good. Now here again, I think most of you, the moment you see the CT scan, you can jump onto the answer, but we can just take the few words from the history also. Vipin Saini, very good. This is subarachnoid hemorrhage. Now here the classical presentation is thunderclap headache. Okay, so I think most of you must be knowing what thunderclap headache is, that it's a very severe kind of headache which the patient has never experienced before, right? So never experienced before. This is one very important clue in the question, right? And the moment you see the, yes, Ishan, absolutely right, thunderclap, and the moment you see the CT scan, you can say that this is a case of subarachnoid hemorrhage, right? Now let me see what are the findings which you have to see in this transverse section CT scan of brain to get to your diagnosis. Now this area is all the area of optic chiasma. We have already discussed, right? So this is the area of all optic chiasma, and what you can see the white shadows, and these white shadows actually reflects collection of blood, right? So these white shadows are actually showing that there is collection of blood. Now what happens, the hemorrhage which is occurring in the subarachnoid space is the place where actually we have the CSF, right? So the blood will go and it will just mix up with all CSF. So all the places of CSF you will see the impression of the blood, right? So two important terms you have to understand while discussing the CT scan of subarachnoid hemorrhage. Number one, of course, this is related to collection of blood. So blood in number one is Sylvian fissure, right? So first thing you have to understand, blood is in Sylvian fissure, and second, the blood is in the basal cisterns, right? So blood is accumulating in the basal cisterns, right? Basal cisterns. Now I think Sylvian fissure, all of you can understand what actually it is. So sylvian fissure, if I draw it, this area is the sylvian fissure area, okay, and here you can see the whiteness, so that is suggesting that there is collection of blood in the sylvian fissure. And sylvian fissure is another term for the lateral sulcus. Now again, you have to visualize in a three-dimensional way. Now this is the basal, this is the transverse section, and now you have to take a lateral section of the brain, and then only you can understand where is lateral sulcus, which is also known as sylvian fissure. So suppose if this is the frontal lobe and this is the temporal lobe, okay, obviously parietal and occipital will go backward. Now this area is, this is the lateral sulcus, okay, so this is the lateral sulcus, which is actually the sylvian fissure, right? Now this we are looking from lateral side, and the CT scan is the transverse section. So again, if you just try to rotate it, and you will understand that this area is actually separating the temporal lobe from the frontal lobe. So somewhere is the temporal, this is frontal, okay. So you have to just visualize the concept. Shahnawaz bhai, good morning. So you have to visualize that concept in your mind, that how transverse view is, how lateral view, sagittal or coronal, whatever, right? So one thing is that the blood will accumulate in this lateral sulcus, which is also known as sylvian fissure, and that is better visualized on the transverse section, number one. Now number two, what you can see that these are all cisterns, right? So these are all cisterns, you can see, and then there are different terms like ambient or other terms, so I won't go into all those details. So these are cisterns. And now what do you mean by the word cisterns? Cisterns are actually pockets, okay, so these are actually pockets of CSF, and when this CSF is mixed with blood, obviously we will see the shadow of the blood in the CT scan, right? So in case of subarachnoid hemorrhage, you have to look for the collection of blood in the basal cisterns and the sylvian fissure, right? This is okay. Now the next question is that why it is that we are getting the collection of blood here only. Now why not at some other place? For that, you have to understand the pathology of subarachnoid hemorrhage. And the pathology of subarachnoid hemorrhage is that, or in other terms, you can say, what is the most common cause of subarachnoid hemorrhage? Now, the subarachnoid hemorrhage is mostly because of rupture of Biliary aneurysm, right? So I think most of you must be knowing what Biliary aneurysm is, and this is actually involving the circle of Willis, right? So it is involving the circle of Willis, and if you have that image of the base of the brain in your mind, you can I think you can appreciate that the location of the circle of Willis is here only, right? So this is the location of the circle of Willis, okay? So this is the location of circle of Willis. So just to help out you in understanding the circle of Willis, I have kept one image also, right? So this is the typical collection of the blood in the basal cisterns, right? So you can see all this is all blood, right? Whatever the white impression you are seeing in the CT scan, this is all blood. And I've just told you, just remember two terms: basal cisterns, sylvian fissure. Just two terms: collection of blood, subarachnoid hemorrhage. That's it. And this is again the lateral fissure, right? So this is the lateral fissure here. This is frontal lobe. Okay, so this is frontal lobe, and this is the temporal lobe. Okay, so you can see the lateral sulcus. Now we will take the opportunity to discuss the circle of Willis also. Now it is very important, because that's why this circle of Willis has been taught always, because of this neurological entity, right? So if you look here, this is the area of the optic chiasma, right? So here we have the optic chiasma, right? And that is all the area of sella turcica and surrounding structures. Now here, what is more important for you to understand, that there is participation of the branches of two arteries in the formation of circle of Willis. From posterior side, the major artery is the basilar artery, right? From the posterior side, the major artery is the basilar artery, and from the front side, the major artery is the internal carotid artery, right? And now basilar artery is one artery which is single in body, because usually when we discuss arteries, we always say right side artery, left side artery, but basilar artery is single, and basilar artery is formed by the fusion of two vertebral arteries, right? So two vertebral arteries they will join and they will form a single basilar artery. Now from this basilar artery, if I show you in the image, this is the basilar artery, okay? So this is the basilar artery, and you can see these are the two vertebral arteries, okay? So the two vertebral arteries, they join to form the basilar artery. Now from this basilar artery, there is origin of two posterior cerebral arteries, right? So from here we will see two posterior cerebral arteries, okay? And I think most of you must be knowing that posterior cerebral artery supplies the occipital lobe of the brain, where we have the visual cortex, right? So this is posterior cerebral artery. Now the other component of the circle of Willis are derived from internal carotid artery, which actually divides into two branches, anterior cerebral artery and the middle cerebral artery, right? So if I show you, this is the internal carotid artery, right? So this is the internal carotid artery, okay, on both sides. Now one branch goes anteriorly, this is the anterior cerebral artery, and one branch goes laterally, this is the middle cerebral artery, okay? So two branches from internal carotid artery, the one which is going laterally is the middle cerebral artery, and the one which is going anteriorly is the anterior cerebral artery. Now I think most of you must be knowing that when we take the arterial supply of the lateral aspect of the brain, majority of the structure is supplied by middle cerebral artery, right? So middle cerebral artery is dominantly supplying the brain on the lateral aspect of brain, right? So this is the branches. Now how this circle is completed, because there has to be a communication between the anterior part of the circle of Willis and the posterior part of the circle of Willis. So for that there are communicating arteries. So now this is the anterior cerebral artery. So the two anterior cerebral arteries, you can say these are the two anterior cerebral arteries, right? So one on the either side, and in between the two we have the anterior communicating artery, right? So this is the anterior communicating artery. Similarly, on the posterior side there is a posterior communicating artery, right? So if we draw something like, okay, this is the posterior cerebral artery, okay? If these are the posterior cerebral arteries, I'm sorry, I'm drawing in green, it should be in red actually. So this is the basilar artery and these are the posterior cerebral artery. Now here there is the internal carotid artery, which is dividing into the anterior cerebral artery and the middle cerebral artery. So this is the middle cerebral artery. Now the posterior communicating artery is joining something like this. So this is the posterior communicating artery. Now the same arrangement is on the other side as well, and therefore it creates a circle, and that circle is known as the circle of Willis. So if I draw you the exact circle of Willis, this is the anterior communicating artery, this is the anterior cerebral artery, right, on the either side. Then this is the posterior communicating artery, again this is the posterior communicating artery, and this is the posterior cerebral artery, right. So it forms a ring around the midbrain area, and this is known as the circle of Willis. Now here, especially around the area of the anterior communicating artery, there is formation of aneurysm, right. So those aneurysms form. Suppose if this is the anterior communicating artery, sometimes there is formation of aneurysm, right. So these are aneurysms, and when they rupture, they cause the bleeding in that area, which is the subarachnoid hemorrhage, right. So that is a very beautiful concept, and I think everyone should know this, and that is what the importance of circle of Willis, because it can lead to subarachnoid hemorrhage, right. So I think now all of you will remember this concept. Okay, so this is the circle of Willis, and it's applied in the form of subarachnoid hemorrhage. Now next question, a girl presented with abdominal pain, right. So she had abdominal pain, and there is blood in stools or mass on palpation, and this is the barium image, right. So here there is blood in stools, and there is a mass which is palpated, and if you look at the barium study, you will see something like this. Yes, any idea what is this? Any idea what is this? It just looks like something like this. Yes, any idea what is this? This looks like a coiled spring. Very good, Ishan, very good, very good. So this is coiled spring sign, and this is suggestive of intussusception. Very good. And that intussusception is also defined in the MCQ statement. So the girl is having, and also the age is also important here, right. So an infant with abdominal pain and blood in stool. Any idea what we call this? Blood in stools in intussusception. Vipin Saini, very good. Shanwas, very good. This is intussusception. Now my question is that there is a specific term for this blood in stool. Any idea what is this blood in stool known as? What is that? KK, yes, intussusception. Very good, Ishan. Very good, Vipin. Yes, so this is red currant jelly, right? So this is red currant jelly stools of intussusception. Very good. And then there is of course a mass on palpation, and that is because of the lump which is formed because of intussusception. Now what is intussusception? Suppose this is the bowel. So what happens? And intussusception is actually known as tube within a tube, right? So what happens? It will go something like this. So it is tube within a tube. So this area will move inside like this. So this is the intussusception, right? And this is the classical coiled spring sign. You can also see a target sign. Okay, you can see a target sign, or you can also see the claw sign. Yeah, right. So these are some other keywords which are very much indicative of intussusception, right? So this is what intussusception is. There is a outer tube which is known as intussuscipiens, and there is an inner tube which is known as intussusceptum, right? So this is intussusception. Okay, so quite easy to identify. Next question. Male presents with recurrent episodes of fever and there is chills with fatigue, and then MRCP image is given, right? So there is fever, chills, fatigue. Okay. So this is actually I think there should be some more points in the clinical history because it is going nowhere. Okay, leave it. So this is actually the biliary tree, right? So this is biliary tree, and here you can see this is actually the area of common hepatic duct. This is the area of the cystic duct, okay? And then this is all the common bile duct, okay? So you can see this is all common bile duct. This is the common hepatic duct, and this is the cystic duct, which is coming from the okay. Pain, jaundice, fever, yeah, that is Charcot's triad. That's why I said there has to be some, jaundice mentioned, something like that, but it's not there in the question. No problem, right? So this is, you can see this is actually primary sclerosing cholangitis, right? So this is primary sclerosing cholangitis, and you can see there is, lot of fibrous. There is a lot of fibrosis as such. So you can see this is the fibrosis thing. Very good, KK. This is primary sclerosing cholangitis, right? So yes, this is primary sclerosing cholangitis, right? So I think there is no much help from the question statement, and you have to simply focus on the MRCP image to get up to the answer. So this is the primary PSC or primary sclerosing cholangitis, right? Chalo, next question is about a lady in first trimester, and then she has been subjected to a single chest X-ray. Now what has to be done next? Very good, very good. So here we need not do anything. We can continue the pregnancy because actually there is a limit of radiation exposure. Shanwaz bilkul theek, Ishan absolutely true. You should continue the pregnancy, right? So there is actually a level of radiation exposure, and if the radiation exposure is below that level, which is found to be a little alarming, if it is below that level, we need not worry, we can continue with the pregnancy, right? So the limit is 0.5 rem or 5 millisievert, and this is what is the permissible dose in a year. So that is permissible radiation dose in a year, and if there is a chest X-ray, it just gives only 0.02 millisievert of radiation dose, right? So this is 0.02, right? And so this gives only 0.02 millisievert, and whereas the permissible is up to 5. So it is far less than what is the alarming dose in pregnancy. So we should not bother too much, and the pregnancy has to be continued without doing any sort of intervention because it is far less than what is the fatal exposure. Now moving forward to Waters' view. What sinus is visualized nicely in Waters' view? Waters' view, any idea? Very good, KK. In Waters' view, it is the best view for maxillary sinus. And here you should remember one more thing, that Shanwaz, very good. Yes. Oh, good, KK, good. I'll remember this also. Very good. So yes, water, you can just reverse it and it will become M. Very good. Yes, Ishan, maxillary. Now there is one more thing which you should know about Waters' view. Yes, it is good for visualizing maxillary, but if you take a open mouth view, you can also visualize one more sinus, and that is, if we take a open mouth view, we can visualize one more sinus beautifully, and that is, I think most of you must be knowing, that is, yes, I am waiting for your answers. Sphenoid. Very good, Shanwas. This is sphenoid, right? So as far as the water's view is concerned, just remember two terms, maxillary sinus and sphenoid, but only if we are taking an open mouth view, right? So that is the condition. Yes, Vipin, very good. KK, perfect. So open mouth view. So this is the water's view, which is mento-occipital view, right? So here we can see this is the maxillary sinus. Okay, so this is the maxillary sinus here, right? So this is the maxillary sinus, and if the person takes an open mouth view, we can see the sphenoid sinus as well, right? So this is water's view. Again, very good question, and this kind of questions are a norm nowadays. Always and always you will have a question about with some labeling, and then you are supposed to identify the structures. Now whenever we have this kind of question, sometimes it might be the case that we don't know the exact answer, but yes, if we can apply the knowledge, we can go somewhere around the answer here. So this question is about the label H, and the label H is this one. Okay, so this is the structure which you have to identify on this transverse, transverse section of the thorax, and you have to identify what is this structure, right? This one. Yes, I am waiting for your answers. Whenever you have a whitish appearance on the CT scan, you have to choose the answer from two options only. One, it can be a bone because it contains calcium, and there is another structure which contains calcium, and what is that? Yes, anyone? What is? Those are blood vessels, right? So two structures will appear whiter on CT scan. Very good. But that is pathology, right? Yes, I do agree that these are normal, right? So let me clarify. Ishan, what is this IPT? I couldn't get the short form actually. It's too short for me to understand. Is it IPT or LPT? What is that? And yes, if we talk about pathology, yes, we discussed in the very first question about carcinopharyngioma, and that is again calcification, or it can be a stone also, right? So any pathological calcification. So you can just summarize it like this, right? So now whenever we are taking the normal structures of the body, and on a CT scan, if we see anything white or what we call radio opaque, we should think it as a bone or some blood vessel, right? Now here, if we take the structures in this section of the thorax, now this is a white structure. We'll go one by one, right? So this is a white structure, and in the front, very good, okay, left pulmonary artery. Okay. Yes, it is blood vessel, so it can be white, right? So we will go one by one now. Now in the front, we know that there is a bone. Now which bone is this? So in the front or anterior, this is sternum. Clear? So this is sternum here, right? So label I is sternum. So I is sternum. Clear? Now we will go posteriorly and we will see that again there is a white structure, and I think it is very easy for us to identify what actually is this. So this one, which is labeled as C, I think everyone can identify what is label C. So label C is the vertebra. Okay, so this is a vertebra, right? You can see the vertebral body. So this is the vertebral body, and these are the posterior element, the lamina and the spinous process. Okay, so this is vertebra. Now on the lateral aspects, you can see here, you can again see some white structures. So I think you can understand what is this. This is actually the ribs. Okay, so these are the ribs, right? So you can understand these are the ribs. Still posteriorly, you can see again a white structure. So this is again a bone, and this is actually scapula. Clear? So this is all the scapula, right? So these are the bony structures which I have defined now. Now we will move on to the inner structure, which are actually the blood channels, blood vessels, right? So now blood can be arterial blood, it can be venous blood. So if you look this and this, these are actually parts of aorta, right? So this is all aorta. So this is, if we visualize it in a different section, this is ascending aorta, this is descending aorta, right? So this is descending aorta, this is ascending aorta. So this one is ascending aorta and this one is descending aorta, right? So whenever you have Ishan, very good, right? So ascending aorta, descending aorta. Now on the right side of the aorta, we have a venous channel, and this is the one which opens into the right atrium. So this is the superior vena cava, right? So this is the superior vena cava. Yes, Ishan, you are absolutely right. Now the blood is appearing whiter and air appears black. So this is also one thing you should understand. Now here in this image, you can see there are black shadows as well, right? So these black shadows are actually the left main bronchus and the right main bronchus, right? So A is left main bronchus and F is the right main bronchus, which arises because of division of the aorta, the trachea. I am extremely sorry, right? So this is the trachea, this is right main bronchus, and this is the left main bronchus. Okay, so they will appear black because they are containing air. Okay, and posterior to trachea, we will have esophagus. So this is the esophagus. Clear? So this is how you will discuss the entire transverse section. Now here you will also see what Ishan was saying before. You can see something like this, right? So this is the pulmonary trunk and the two branches, the right pulmonary artery and the left pulmonary artery, right? So pulmonary trunk with right pulmonary artery and left pulmonary artery. Okay, so this is the transverse section of the thorax, and again it is a very important question, and most of the time we have a question based on this thing, right? So this is the thing. Now one very again a very interesting question, and this is about angiography of the gastrointestinal vessels, and we have to identify what actually the label 13 is. So this is the angiogram of, this is GI vessels, right? So they haven't mentioned the site as such, and then we have to identify which is this structure, right? So we have to identify what is this structure. Now firstly tell me what you can see here. Now what is this actually? Any idea what is this? Just going down and then bifurcating into two, then again bifurcating into two. And here also we can see two branches, something like this, right? Very good, very good. So this is actually very good, Vipin Saini, very good. So this is actually inferior mesenteric artery, right? And this is abdominal aorta, right? So this is abdominal aorta, and then you can see one artery going like this. This is the splenic artery, right? So this is splenic artery. Then here you can see there is one artery which is going on to the right side, and this is the hepatic artery. Then you can see two branches. This is the left renal artery, this is the right renal artery, right? And of course this is the inferior mesenteric artery. Then these are the this is the two divisions which are the common iliac arteries, right? So these are the common iliac arteries which divides further into the internal iliac and the external iliac artery, right? So internal iliac artery and external iliac artery, right? So this is a basic representation of the abdominal aorta and its branches, right? And again I am telling you, it is very complex anatomy, although when we discuss we always define, or we always discuss it in a very simple manner, but it is very complex, right? And sometimes we have one more question about IMA, the level, the vertebral level of origin, and that is L3, right? So this is L3. So for this I have kept okay, yeah, here it is. So just the important ones we will take, and we know that from abdominal aorta there are three important branches, and I think this we have already discussed before in anatomy also. One is the celiac trunk, right? Second is superior mesenteric artery, and the third is inferior mesenteric artery, right? And they have specific areas to supply. So this supplies the foregut derivatives, this midgut derivatives, and this is the hindgut derivatives, right? So I won't go into too much of details. And so this is the celiac trunk here, okay? So the celiac trunk, and then celiac trunk has a lot of branches. So the celiac trunk is at the level of T12, right? And slightly below the celiac trunk is the origin of the superior mesenteric artery, and superior mesenteric artery is the level of L1, and lower down there is inferior mesenteric artery, and this inferior mesenteric artery is at the level of L3. So everyone has to remember these few branches. One is the celiac trunk, then second is the superior mesenteric artery, and the third is the inferior mesenteric artery and their vertebral levels, right? And then of course it is quite easy for you to mark out the two renal arteries, like the right renal artery and the left renal artery, okay? So just remember these much. And again in this particular thing you can see in this angiography you can see this is the right renal artery, this is the left renal artery, okay? This curved one is the splenic artery here, okay? And then the hepatic artery which divides further, then this is all the common iliac which divides further into the external and the internal iliac artery, right? And somewhere here is the origin of the inferior mesenteric artery. So this is the inferior mesenteric artery, something like this. Okay, so this question was about inferior mesenteric artery, right? So again, this is also a very important source of question. Sometimes you might have simple images, or sometimes you might have angiographic images, and they will just point at some structure and you have to identify, right? So just get to know the basic, the important ones only. No need to read the entire image, right? So these are the things, these are the three common ones which you should remember. Chalo, next question. Now, what is this radiological investigation known as? Now here what you can see duodenum, you can see jejunum, and you can see ileum. So it means this investigation is helping us to study the small intestine. Now what is this known as? Of course, and I think most of you must agree that this is of course a barium study. So barium study for small intestine is known as. Any idea what is this known as? This is known as barium meal follow through. Okay, so this is barium meal follow through. Similarly, I think if you know, like if you are studying esophagus anatomy, that is known as barium. Very good, Ishan. This is follow through, yes. If we want to study the anatomy of esophagus, we do barium swallow, right? Then if we want to study stomach, we do barium meal, right? And for large intestine, we do barium enema. Clear? So these are few different terms depending on which part of the GIT we are studying, right? So follow through for small intestine, then swallow for esophagus, then meal for stomach, and enema for large intestine, right? So this is in short. Chalo, next question, and I think it is one of the most easiest question you can ever have in radiology, and not for NEET-PG, even in FMG, everywhere we have this kind of question where a patient presents with abdominal pain, and then we have a X-ray which shows now this white line is actually the dome of diaphragm. Okay, so this is the dome of diaphragm. Clear? So we can see the dome of diaphragm on the either side. So this is dome, right? And then just below the dome, very good Vipin, we can see a black shadow. Now this black shadow is all the air under diaphragm, right? So this black shadow is all air under diaphragm. Air under diaphragm. Clear? So yes, air under diaphragm, this is pneumoperitoneum. Okay, and whenever you have pneumoperitoneum kind of picture, it means there is some viscous, yes, so there is some hollow viscous perforation, and whenever there is perforation, it is a surgical emergency. So what you need to do? Open the abdomen immediately, right? And this is known as laparotomy. Okay, so this is laparotomy. Clear? So this is emergency actually. Clear? Yes, if you don't address, it can lead to perforation peritonitis, because whatever the gut content leaks out, it is very irritating for the peritoneal cavity, so that leads to perforation peritonitis, right? So this is a classical case, and usually we see with ulcer for perforation usually, but it can be with typhoid as well. Chalo, now X-ray abdomen has been given, and we need to identify what it can be. So of course it is an X-ray. Yes, KK, yes, we need to plan it accordingly, but we need to go for laparotomy. Yes. So you can see this is a abdominal X-ray of a child, and what you can see here, these are all ribs. Okay, you can see the vertebral bodies and then the iliac wings here. Now what is missing from here? Yes, very good. What is missing from here, that we don't find any gas shadows. So gas shadows of the intestine, they are absent, and this is known as gasless abdomen, right? So this is gasless abdomen, and gasless abdomen is, it can be seen in acute pancreatitis, right? So this is gasless abdomen. You are not seeing any sort of bowel shadows here. So this is gasless abdomen, suggestive of acute pancreatitis. Yes, Ishan, KK, both of you are correct. So this is gasless abdomen. Okay, and I think this is again a very basic question. If a patient is having mitral stenosis, and if you do barium swallow, you will see indentation of esophagus, and this is because of enlargement of which chamber of heart? So on barium swallow, you will see indentation of the esophagus. So suppose if this is the normal esophageal outline, what will happen in case of, this is say normal, okay? Now what will happen in a case of mitral stenosis? You will find is something like this. So this is in a case of mitral stenosis. So there is some backward pushing of the esophageal wall, and this is actually pushed by, and I think whenever we are saying mitral stenosis, you can say which chamber is enlarged. So the chamber enlarged is, which chamber is enlarged in mitral stenosis? Because say this is left atrium, this is left ventricle, so here is all mitral stenosis. So it means very less amount of blood is going to left ventricle. So what will happen? There will be enlargement of left atrium, right? So this is all, also you can just discuss the pathology, and you can just consider the pathology, and you can say that there is enlargement of the left atrium. There will not be enlargement of left ventricle because through that stenosed valve already the blood is going very less in amount to left ventricle. So there is no point in having hypertrophy of left ventricle, right? There will be hypertrophy of left atrium, right? So this chamber is actually the left atrium, which will push. No problem. At times we can confuse. So as a human, that is natural, and that is bound to happen. When one cannot be immune to mistakes, that's true, right? But the only thing is that just make sure that they are not repeated, at least in the exam, right? So here you can see this is the left atrium, which is causing an indentation over the barium swallow image in esophagus, right? So that we know because that is the pathology of mitral stenosis. Now a patient presented with low grade fever, and we did chest x-ray, and we found something like this. What can you see in this particular chest x-ray? The moment you get this word, low grade fever, right? Always put one condition on the top, especially in Indian setup, right? Although the list is endless, but start with tuberculosis, right? And in this case, in relation to tuberculosis, what you can answer, right? You will see small white dots all around, right? So on the both side of the lung fields, you can see small white dots, and especially in a case of tuberculosis, what pathology you can think small white dots, just looking like the millet seeds. Very good, Ishan. This is miliary tuberculosis, right? So this is miliary tuberculosis, and we are having the involvement of both sides. So this is bilateral, and that happens because of the hematogenous spread of the bacilli, right? So this is miliary tuberculosis, and you can just presume the appearance like the millet seeds, right? So this is miliary tuberculosis. Okay, so one very okay, so miliary tuberculosis. Now this is one very important question which has been repeated over the years, and in the intravenous urography, what sign you can see, and based on that what condition you can think of. In older times they used to just mention the name of that thing and they were supposed to answer, but nowadays they are just confusing the things. They are not giving you any sort of hint, they are just giving you the image, and now you have to apply your knowledge. And yes, Ishan is absolutely right. This is the typical cobra head appearance, right? So this is the cobra head appearance, and yes, when you get the word cobra head appearance or adder head appearance, the answer will be ureterocele. Okay, so this is actually the dye within the urinary bladder, and this is the ureter actually, right? So this is the ureter, and ureterocele means there is dilatation of the terminal part of ureter, so that gives a typical, I think it's better on this eye view. So here you can see this is all the dye in the urinary bladder, and then the ureterocele part is this one. The ureterocele part is this one, right? So it looks like a cobra head appearance, right? So this is the cobra head or adder appearance of ureterocele, right? Yes, Shanawaz bhai, you are right. That is miliary tuberculosis. Miliary, okay? So this is adder head appearance and very suggestive of ureterocele, okay? So I think, yes, that's the end of this session, and from today I have just tried to change the timings because I cannot continue for late night classes because next week you people have your exams. So just to make sure that you are active in the daytime, right? So yes, Shahnawaz bhai, दीपक भाई आप बिल्कुल परेशान मत हो. 9 और 10 को मैं हिंदी में ही लूँगा, ठीक है? 9 और 10 को मैंने हिंदी के सेशंस के लिए रखा है, और जितने भी अभी मैंने डिस्कस किए हैं इन्हीं सबको मैं एक फटाफट क्विक रिकैप हिंदी में करूँगा, राइट? सो मुझे याद है 9 और 10 आप नोट कर लो. सो 9th and 10th वी विल हैव ऑल हिंदी सेशंस of the same sessions whatever we have already done in English. So just to make sure that thank you, Shan. I'm just trying my level best as a human, right? So that's the end of today's session. Tomorrow we will take psychiatry, right? So see you tomorrow 8 a.m. Indian Standard Time. Till then, bye bye.